Yep.
Welcome everybody. So welcome to the latest in the Dean's Seminar series. And I'm really pleased to have Meredith here today, who I know will give a fantastic talk, which is modelling for us right there. So for those that don't know Meredith, Meredith Makeham is the Chief Medical Advisor of the Australian Digital Health Agency. And I met Meredith recently. We had dinner together in the city, and when she was down in Melbourne. And there's a lot of work going on in digital health, both within the faculty, but also within other faculties across the Monash University. And so I'm really pleased that Meredith is going to tell us a little bit about the work going on with the Australian Digital Health Agency today. Just to give you an idea of who she is, so in her current role, she's leading the development of initiatives to ensure that digital health technology in Australia is designed, built, and evaluated in close collaboration with the research community. So no small task right there. But she's also a general practitioner based in Sydney. She's a member of the Clinical Advisory Council for the Sydney North Health Network, or something.
Something like that, yeah.
The PHN. And you know, look, she's a fellow of the Royal Australian College of General Practitioners as well, and lots of other accolades and so forth. I won't say any more because she's literally on a flying visit. She just landed, came straight from the airport, and she has to run off about 10 minutes after the end of the talk to get back to the airport and back to Sydney. She's a very busy person, so we're really privileged that she's made time available for us today, and I'm really looking forward to hearing the talk, and I'll let you take it away.
Thank you, John. Thank you. All right. Well, thanks for those kind words. Good afternoon, everyone, and thank you for the invitation to speak at Monash today, and it's a real pleasure to be here with you all. And yes, apologies about the flying visit, but I did have an opportunity to educate your Dean about the importance of the Spring Racing Carnival, because this, I believe, is his first Melbourne Cup in Australia. So rest assured we've got that in hand now, otherwise there could have been quite a disaster next week on Tuesday. But look, before I begin, I wish to acknowledge the people of the Kulin Nations on whose land we're gathered today, and I pay my respects to their elders past and present. Look, this afternoon I want to talk to you about our National Direction for Digital Health Services and Technologies, and how the organisation I work for, called the Australian Digital Health Agency, is working really hard to create the foundations of a digitally enabled health system, a modern digitally enabled health system for all Australians. And these foundations, like our National Digital Health Strategy and our My Health Records system, are examples of those that I'll go into in more detail. As John mentioned, I'm the Chief Medical Advisor at the Australian Digital Health Agency, and at the agency I'm actually responsible for leading our research and evaluation strategies and the collaboration with the academic community and engagement with the academic community and digital health sector. And I really love meeting the amazingly talented minds of the researchers and innovators that I have the pleasure to work with in this role, but I'm particularly excited because I get to witness all of these things like artificial intelligence. Oh yes, hello. Ah, someone's fixed it. So, was that coming through from Caulfield perhaps? Apologies. All right, well now, there was a bit of background noise. Yeah, it was a little bit. Anyway, talking away blithely. All right, so where was I? I was saying that, yeah, so essentially, you know, we're doing some really interesting things and working with a lot of innovators and developers at the Australian Digital Health Agency. One of the interesting things I'm doing at the moment is leading a fabulous group of people from the agency and in conjunction with the Australian Genomics Health Alliance, and we're thinking about the way our national digital infrastructure needs to evolve to support the tsunami of information coming our way when we all have our gene sequence, for example. And you know, when we think about that, though, we have to also remember that health IT researchers, and I know not everyone in this room is health IT research, it's a broad church, the IT faculty, but obviously health IT is a focus of our organisation. And we need to consider the technical and behavioural changes that we have to encourage in order to support all of these changes that are coming. So I see the future of health IT research as really bringing together those fields of pure technology innovation and also behavioural economics. And as John also mentioned, I'm also a GP, so, and practising in Sydney. usually only once a week these days, but I have a great time getting together with my patients, and it provides me with a very humbling opportunity to think about the way cutting-edge research, technology and great intentions can really falter when they meet the sometimes seemingly impenetrable wall of reality that is actually our complex clinical environment in Australia. And so how translating the brilliant ideas that come out of universities like Monash and other research institutions is really quite a challenging task. So I have some more reflections to share with you on that a little bit later. But I also want you to ask you to think about the reason we should invest public funding in any service for our community. And the way that, you know, fundamentally relating to the title of my talk here, it's because it will provide some form of benefit to the society, to our citizens. And we need to think about, well, what is a benefit in the field of digital health? You know, how can we know if we've achieved success in delivering these benefits? And this is where the academic community is critically important, because we have to work with innovators, developments, governments, and the broader community, people, to really guide our understanding of what people want and need with respect to their health services in order to gain benefits. And we need to define what those benefits are and what our understanding is of the outcome measures we need to be using that would indicate success, and whether or not we've achieved it. So we really need your guidance to help us measure all of these things with academic rigour, which is sometimes sadly missing when we have government investment in areas. It's not always backed with cutting edge research that's been done with academic rigour. So I'd like to encourage that more and use your creativity to explore new ways to achieve those benefits for people, and think about how we're winning when it comes to digital health services and technologies. So let me now show you a photo of a beautiful statue of someone you'll all be terribly familiar with, of course, Sir John Monash. And I was very pleased to read on your website that he thought a lot about benefits as well. And this quote there, equip yourself for life, not solely for your own benefit, but for the benefit of the whole community. So, you know, digital health services and innovations really provide us with opportunities to deliver healthcare with a greatly enhanced ability for people and their clinicians to make better and safer clinical decisions. And they also support huge improvements in health system efficiency for the community and far greater equity of access for services for all of our citizens. So in fact, digital inclusion is a concept that's been spoken about a lot recently and raised as something that should be considered as a basic human right. We should strive to ensure that all of our citizens have equitable access to digital services, including those designed for delivering improved health benefits. So I wanted to also set the scene for you in terms of healthcare in Australia today. And here's a pretty graph that I've lifted from a recent Commonwealth Fund report. So a comparison of 11 countries here. And you can see that we have one of the best healthcare systems in the world by these measures. We're at the forefront of medical research. We've got world-class facilities, and the people that provide care are highly skilled, capable and professional. This graph shows us recent data on healthcare system performance compared to spending, and Australia's ranked as close to the highest on that measure, healthcare spending as a percentage of GDP. However, a person's ability to access the best quality care can actually be very limited by their geography, and a healthcare provider's ability to deliver effective care can be limited if they don't have access to health information that they need to gain a complete picture of the patient that's sitting with them. And so, you know, we know things aren't working perfectly, although we measure up well, and perhaps even close to perfectly, unfortunately, in some healthcare settings that I'm quite familiar with. There is compelling research evidence out there that digital health services can help us make it a lot better for people and their clinicians. The reality of the health system where I work in general practice is that my everyday includes, you know, dealing with missing clinical information, which causes wasted time and safety gaps. And when that critical data isn't available at the time it's needed for me to make a well-informed clinical decision, that puts the patient I'm with at risk. I encounter serious harms, and even in the broader system, we see a lot of deaths related to potentially avoidable adverse drug events and medication errors, because accurate medicine information isn't shared between clinicians and health services. And I also see a lot of wasted resources and health system inefficiencies related to things like blood tests and x-rays being repeated because clinicians are either unaware or unable to easily access investigation results for people. So, you know, as your GP, if I can see that you've had an x-ray or a blood test in hospital yesterday, I'm not going to repeat it again today. And vice versa for my hospital colleagues. But also, really importantly, I see a lot of disempowered people and people who have no access to their own health information, although it's a right for Australian citizens, which would transform their ability to be, you know, more engaged with their health and care and active participants and be able to, you know, experience what we're aiming for, which is for people to experience healthier and happier lives. So I've been a GP for about 20 years, and I work with a group of GPs who have a practice that's as close to paperless as we can make it. You know, we operate a digital clinical information system. We send our referrals electronically using secure messaging. We do all of our record keeping and prescription writing and everything like that on our system on the computer. But look, when I arrive at my practice, my first port of call, as has been the case for the entire time I've been a GP, is always my paper in tray, which is usually overflowing with letters and faxes. And the first thing I have to do is go through that information and then manually enter all of the data in those letters and faxes back into my machine. I have to have all those bits of paper scanned, which causes a huge amount of waste in terms of storage and space. And it's just a very frustrating thing. So, you know, in order to do cleverer things for my patients as well with that data and information, I can't do it unless it comes in a digital form that I can then use for stuff like clinical decision support, or, you know, actually moving towards something really exciting like an environment where we're actually able to practice precision medicine or personalised medicine. So you can see the difficulty that we're facing is that we've got amazing innovation in health IT in Australia juxtaposed to systems where clinicians don't even have a computer in their practice from time to time, or they may have a system but aren't using it to its full effect, or it's just simply not interoperable with anyone else. So we can't share our information and do anything clever with it and move healthcare ahead. So I'll tell you a little bit more about the Australian Digital Health Agency, and it was really created because we do need nationally led initiatives to try and solve these problems of technology adoption and system interoperability. And it's really important to have an organisation help us tackle these types of issues for the public good. The Australian Digital Health Agency is a relatively young agency. We commenced on the 1st of July last year. We're funded by all Australian governments, so accountable to the COAG Health Council and the Federal Minister of Health. And we brought together a number of functions that were previously delivered by one of our predecessor organisations called NETA. And we've built upon some of the important national digital infrastructure that NETA built, and we've added to that other functions, including things that were previously run by the Department of Health as the system operator of the My Health Record system. So we were created to improve health outcomes for Australians through the delivery of digital healthcare systems and a national digital health strategy. Now, please, eyes don't glaze over when I say strategy, or think of a Utopia episode that I saw recently. But really, our purpose and role is laid out in the legislation that established us and created the agency. And you know, the creation of a national digital health strategy was one of the first important steps that we had to deliver to guide the national direction of digital health services. And it was a very important moment to get that through, because it's been quite a number of years since Australia's actually had a blueprint or a clear direction for what people in the broader sector actually want to have delivered and what people expect their digital health services to deliver. There had been a previous strategy many years ago in Australia. It was in 2009. It had a bit of an update in 2013. But this was an opportunity to really bring the community together. And, you know, I'm pleased to say that it was approved unanimously by all the Australian health ministers quite recently. It was in August, I believe, and it's available for you to read on our website. It included also a substantial review of the domestic and international academic literature on the benefits of digital health services and technologies. I made sure of that, and that guided our development of the document, along with a broad consultation process that we undertook. So we spoke to over 3,000 Australians in order to develop this strategy, including clinicians and researchers, industry, and of course patients in the community. And they shared their views on a range of activities, including, lots of town hall forums and workshops. We went all over the country, regional areas and remote areas as well. And people told us what their views were on the way the health system worked for them today and what they wanted out of their future health and care system to be, and how they wanted us to prioritise investment. So here's one of the really interesting things we discovered, and apologies, it is a little small up there on the screen, but this shows you that when we consulted with the healthcare professionals, it wasn't actually the large proportion of these clinicians that wanted to use more digital technology to help them share information with their patients and each other and communicate with people before and after consultations and those sorts of areas, which are the things listed there with the proportions of people that want to do those things. But the far right column shows that there was a significant minority of clinicians who had absolutely no interest in digital at all, in using services to do any of those activities at all. And that's a really interesting group of people that we need to try and better understand from a research perspective, I believe, in order to come up with strategies to actually reduce that digital health divide that exists and that's really holding back progress in a lot of our clinical settings today. Is it simply a fear of change, or is it a threat to our sort of imperfect but well-entrenched funding models for healthcare services? We need to explore this group more carefully to discover where these barriers could be. So it's also worth a moment of reflection, I feel, at this point, to note that this potential for technological advances isn't, the threat of it isn't a new phenomenon. And while we might think about, health technology as virtual reality headsets and, robotic surgical arms and those sorts of things, it's really nothing new. So books and writing and the pen at one point in time were seen as radical new technology as well. And Socrates was concerned here about people learning how to write and then losing their memories because they wouldn't practice remembering things anymore if they wrote them all down. So it could be true, actually, partly. I did write down some notes today that I could have otherwise remembered for you, but anyway. So, the pen, which was this piece of technology in its own right, took 4,500 years to reach 50 million users. And you think about then the rapid way we're now going into the uptake of information technology across the board. We can say that it feels like things are getting faster and faster. So to reach 50 million users, the telephone took 75 years, the radio took 38 years, TV took 13 years, the internet took 4 years, Facebook took 2 very short years, and Angry Birds took 35 days. So I can't see anyone playing Angry Birds, that's reassuring. But anyway, when we consulted the Australians that weren't playing Angry Birds and asked them, what they wanted from digital health services, it wasn't any great surprise. It just reflected the broader expectation we now all have of the way digital supports us in every other part of our lives. So we use it for services like education and travel and banking, social connections. And, we're a country with over 15 million Facebook users. About 19 million people have got mobile phones, or there are 19 million mobile phones floating around the community. And we've got an average of 9 connected devices per household in Australia. So our national digital health strategy reflected these 4 areas. This is what people said they wanted. From the person's perspective, we tried to frame this as being about the person. And it says, support me in making the right healthcare choices and provide me with options, create an environment where my healthcare providers and I can use and benefit from innovative technologies, which is where the academic sector comes in a lot as well, creating that environment and working out what it should look like in the future. Helping all the people who care for me to understand me and together provide me with safe and personalised care. And that's about connecting the dots as well. And preserve my trust in the healthcare system and protect my rights. And our feeling of privacy about our health information is a very, very important thing in Australia. It's perhaps, it varies from country to country, but in Australia, that's a really critical fundamental right that we are making sure that our health services are protecting. these are the pillars that were developed to support those themes, and it really just spoke to the broad range of fundamental components of the Australian digital health ecosystem. There's quite basic things in there, just getting those things in areas like secure communications with each other digitally rather than resorting to fax machines, improving the interoperability of our systems, and we want to be able to share high quality clinical data with a common meaning. And the first priority of the strategy is something quite simple, and I'd argue that perhaps this is, a basic human right in the information age in which we live, and that's that every citizen can access their health information on their mobile phone, if that's how they choose to, whenever they want to, and decide who else gets to see it. And, My Health Record is the centrepiece of that ambition. So I'm going to quickly touch on, I'll explain My Health Record to the room because I'm anticipating about 20% of you have one, in which case you may or may not really understand what it does, but I'd like to sort of make it clearer for you all. So it's really quite an important global innovation in consumer empowerment in health and wellbeing. It gives people and their clinicians access to their personal health information. It will transform the way we practice as we start to change our workflows around having access to this new information, all of us. And it will deliver a range of benefits. It will really save lives and time and valuable health resources for Australia. When I explain My Health Record to my patients who are thinking about opening a record, and we can sign people up easily in the practice, or you can jump onto the MyGov website and do it very quickly and easily online. You could do it right now. But you have to be able to remember when you last saw your GP or tricky questions like that, as well as a bunch of other things to securely identify yourself, of course. But what I tell them is it's basically a secure online summary of your important pieces of your health information, and you can access it and control who gets to see it. But every healthcare provider, every clinical service that you see in the Australian community is able to put information in there for you if you so choose to let them do that. It's a really powerful tool for making sure that everyone can see all of the same accurate information at the same time and at the point of care at the time you need to see it. It presents information from across all the areas of the health system. Essentially, any clinician in Australia who is registered with AHPRA, which is our Australian Health Practitioners Registration Authority, is able to... Sorry, that's me. Sorry about that. So anyway, any clinician that is registered with AHPRA and has a conformant clinical information system in their software is actually able to put information in there for you. And so that's things like a GP uploading shared health summaries, the hospitals uploading discharge summaries, Medicare data, prescription data, public and private pathology are now going up, and lots of other things. It also allows you to access the Australian Immunisation Register. It allows you to access the Australian Organ Donor Registry. So all of the bits of your health and care that you want to be able to put in one place together like a bank account, that's what it gives you access to. It also actually lets you enter information yourself. And I'll talk more about that in a minute, but we have consumer entered notes, and you can put your own over-the-counter prescription, over-the-counter medications in, for example, or put up an advanced care plan, which is a very topical issue right now, of course, in Victoria. So using the My Health Record to actually be the tool, the vehicle through which clinicians will be able to see advanced care plans will be a step that might be a logical next step for the Victorian government to consider as it implements changes to advanced care plan regulation. So we've been working really hard at the Australian Digital Health Agency to enhance the design of My Health Record, which has been constantly evolving since its inception, and a lot of the clinical community weren't particularly engaged with the way it looked before, and it's been going through a lot of improvements in its look and feel, but also in the clinical quality of the information going in there and making sure it's got rich clinical information in there for people. Because really that's the best, to give people the best possible experience of it means that they'll use it, and then there's the best possible chance that we'll all get the benefit of people using the system. So I always address this at this point because it's the first question if I don't. So what about my privacy? How do I control access to this thing? The My Health Record legislative framework is world leading. It really places the consumer right at the centre and controls the information. you have that power to add information, to restrict access to certain documents, and even remove documents from the record. So in 2012, the Australian Parliament passed the legislation that established My Health Record, and the legislation also established a series of privacy safeguards that are really the best in the world for a system like this. And there are a small number of other countries, actually a lot smaller than Australia generally speaking, some Scandinavian and European countries that have set up a national system like this, but the citizens of those countries either can't see it or don't have the right to opt out of it or don't have any of these privacy controls that we've built into it. So it enables you to do things like setting a PIN code over your whole record. So that means nobody can see it unless you share that code with them. You can also set a PIN over certain documents. So you can pick and choose which clinicians you want to allow access to your entire record and which you need to share that code with for them to see specific documents. So you can imagine if, for example, you wanted your general practitioner to be able to see your mental health care records, but you might not want an allied healthcare professional you're visiting for a sore knee or physiotherapist, for example, to be able to see that note. Then you can actually block it with a PIN, and you'd have to share the PIN with the physio if you wanted them to see it. You can also choose to block healthcare provider organisations entirely from being able to view your record. If you decided that you've left a practice and you don't want them to have access to your information anymore, you can actually just completely block them. You can also completely remove a clinical document from the system or obscure it essentially for all intents and purposes. And that was a privacy, I'll use the word battle actually, which, you know, for some parts of the clinical community was a very challenging notion that people could actually take that step to completely obscure, remove a document that their clinician had put up there. And it also gives you access to a real-time audit log of all of those people who've ever viewed it or put information in there for you. So that's for all time. So those protections there, and I'll mention though, in the event of an emergency, a clinician can break the glass on access controls if they need to be able to see, for example, your medicines and allergies. And you know, when you're unconscious, that could save your life if you're in an emergency situation. So in addition to those things, the legislation also has criminal penalties and custodial sentences if a clinician were to, or someone were to access the system and do any of those things without a reasonable need. And, you know, happily, with this thing running for over 5 years and over 5 million people now in the system, there have been no instances of clinicians doing that. So they're all very aware when they join their system. It's very clear. It doesn't actually vary from any other ethical principles that clinicians practice by. So it's in line with our regular ethics of privacy of healthcare information. So just to give you a bit of a feel for what's going on, as I said, we've got more than 5 million people, 5.2 million at the moment with a My Health record. There's an average of one new record, or more than one new record being created every minute, and over 10,000 healthcare providers are connected. GPs, hospitals, pharmacies, aged care, residential services, not so much using them, but now being connected, and allied health services we're encouraging as well. Anyone really, as I said, from an AHPRA registration who has a conformant clinical software system is able to make that connection. And we've got over 2 million clinical documents sitting up there and 12.5 million prescriptions and dispense records, et cetera, So, and I believe that we'll be able to share these slides with people afterwards, of course, as well. So you'll see all those figures in there. So in May this year, the Australian government went a step further. So on the overwhelming evidence from 2 opt-out trial regions where we had over 1 million people given automatically a My Health record in far north Queensland and the Nepean Blue Mountains region of New South Wales. The clinicians and consumers in those regions that went through this trial were overwhelmingly positive about having that just automatic access to the My Health record system. And we found that less than 2% of people with adequate education about how to do so chose to opt out of the system. So we anticipate that, you know, as a result of this, the government announced in the budget this year $374 million to ensure that the My Health record system was expanded to all Australians by the end of 2018. Unless you choose not to have one, of course, there will be an opt-out period built in to 2018 where people with a big education campaign will be able to opt out of the system if they don't want to have a My Health record. And of course, afterwards, if you change your mind later, you can opt out then as well, or exercise all of those privacy controls that we spoke about. So one of the really important drivers for this, and one of the reasons that we're doing this transition to an opt-out system, is it's going to massively bring forward all of the benefits that we anticipate will happen with the system many years sooner than slowly having people opt into the system, which delays clinician uptake as well. So it will give people the benefit, but still provide them with that ultimate choice of not being in the system if they don't want to be. So how will Australians benefit from the My Health Record? Thinking about what those benefits are and what we need our academic community to think about helping us build the evidence for and proving. There's quite compelling evidence that if you give everyone access to a system like My Health Record and allow clinicians to access those records as well, it's going to, as I said, save time and money and lives, but in more detail, it really enables systematic safety improvements in the healthcare system, particularly in medication safety. We believe there'll be a reduction in medication safety adverse events and medication errors. And one of the reasons for this is a very recent release, just in June, in fact, is a new feature in the My Health Record for consumers and clinicians. Everyone can see it, called the Medicines View. And GPs really love it. It's from the point of view of a clinician attempting to do a medication reconciliation. It's basically makes your job so much easier, because what it does, it brings together all of the medicines information from the different parts of the system that My Health Record accesses or has access and inputs from. So from the hospital discharge letter, from the general practitioner's shared health summary, from your pharmacist's dispense records that get uploaded, from your own consumer entered health notes. It brings all of that together in one view and allows you to actually see the most accurate picture of what someone's taking across the board and what they've recently purchased, etc. And it also shows the same thing for their allergy information from all of those places. So putting all of that together in one place means that a physician in emergency or your general practitioner is much less likely to make a mistake when they're trying to, say, prescribe you a new medication, or do something with medications that might cause you a serious harm or potentially put you in hospital. We know that 2 to 3% of all hospital admissions are actually related to medication errors in primary care. So we expect this system will reduce avoidable hospital admissions, and it will also improve healthcare coordination, because all of the clinicians in your primary care team and at the hospital as well will be able to see that same information and coordinate your care more efficiently. And so you'll be able to see that information as well, and you're much less likely to require contact, I guess, with the healthcare system if everything's clearer and there's a plan and we all know what's going on, which should be a cost saving for the system as well. But really it will result in improved self-management for people. And when you're empowered to be that participant in your own health and care, you're much better able to self-manage your own illnesses or medical conditions. You are also just generally you feel more comfortable and happy. I mean, it's a really hard thing to measure, but certainly there's information from systems like Open Notes in the US that show a great improvement in people's satisfaction and reduction in anxiety and much greater adherence to medical treatment and that sort of thing. And that's just through simply being able to see the medicines list that they're on and understand the notes that their doctor made and instructions that they were given. So we're also really important to point to there as well, as we're likely to see significant health system savings through a reduction in unnecessarily duplicated tests. So as I said before, if I can see you had a test recently in another part of the system, I'm not going to do it again. And that's an expense, as well as obviously the inconvenience to people, and in some cases even a harm, like, potential radiation exposure if you're repeating a CT abdomen, for example. So I wanted to share a case study with you that demonstrates the kind of benefits we can see in a region where everyone's been given a My Health Record. So my colleague, Dr. Liz Jackson's an obstetrician in Cairns, and she's shown me the fantastic improvements that she's been able to make using My Health Record for her obstetrics patients, because during pregnancy, all of our vital health information is recorded manually in Australia on a yellow antenatal card, which pregnant ladies carry around with them and frequently lose, in my experience, as their GP. And it's the mechanism by which we do shared care with obstetricians. So It's an imperfect paper-based system, but obviously it's really important that we've got that information about all of your blood group and complications and details of the pregnancy, etc. But Liz has actually used My Health Record and a feature in there called an event summary to essentially create a digital version of your antenatal card. And her patients can view it on their mobile phone and through a consumer app that we now have actually got 4 apps connected to the My Health Record system. So the My Health Record system is a platform and app sitting on top of it. But this means that these ladies don't lose that yellow antenatal card. They've got it with them all the time. And their GP can then click on the My Health Record tab in their clinical information system at the practice and see the same accurate information there digitally, whether the lady remembered to bring the yellow card in or not. But really vitally important, Liz has got it set up so the midwives at the delivery suite can access the My Health Record system and see this event summary antenatal card as well. So that means when someone's unexpectedly going into labour in an emergency situation, perhaps having bleeding, etc., and in a region like Far North Queensland, they might be coming from some distance and by ambulance or an emergency transfer. They can see all of the details about that lady's pregnancy while she's in transit. They can start getting equipment ready, they can get theatre ready, they can get bloods ready. It's really changing the way they're able to practice more safely to the great benefit of people. And we've heard a number of stories about this from the people in that region, which we'll be putting together as a qualitative case study exercise as well. But that's the sort of real life effect that this system's having on people who now have access to the My Health Record system. And they're incredibly positive about the system in Queensland and in the Blue Mountains where they've all got it. So I thought I'd also briefly say, as well as obviously focus on the benefits of My Health Record and the research that we're trying to drive around building the evidence base for those benefits, I wanted to highlight some of the agency's other focus areas, and just briefly to say one of the pillars of the strategy called the Enhanced Models of Care has given us an opportunity to run a series of innovation and research test beds, if you like, across a range of health IT areas. And things such as we've set up a children's collaborative to digitise and harmonise all of the different state-based, manually paper-based written blue books, they're called in New South Wales. They're a different colour in every state as well, but we've got a great project going on to digitise those. And as well as projects in advanced care planning, emergency care, creating emergency use cases for My Health Record and improving the use of it in emergency departments. Also working with other parts of government on a project called Healthcare Homes, which essentially allows people to register with a general practice if they choose, if they've got complex and chronic conditions, and gives all of the access to their treating team through My Health Record. And telehealth. And we've got a lot of work going on in telehealth in the Northern Territory as well, is one of the focus areas. And we're building on leading Australian research like this CSIRO trial, where we've got really good evidence from Professor Branco-Cella and the CSIRO team that ran this extensive trial of telehealth to prove that it greatly reduced costs and reduced primary care visits and unscheduled hospital admissions by about 1/3, and they reduced hospital length of stay for these people by 42%. And there was a really strong acceptance. The vast majority of people using these digital telehealth services would recommend it and want to use it, and the clinicians loved it as well. But look, this brings me back to the point I made at the beginning about the translation of research and innovation into real life, into clinical practice, into people's everyday. And I recently had the privilege of visiting a remote Aboriginal community in the Northern Territory, about 2 hours from Alice Springs. And they had amazing facilities set up there with telehealth services where they could, be having a consultation with a physician in Adelaide, thousands of miles away. And the issue was that the cultural change that we need for clinicians and people to actually adopt our technological innovations is something that's a far greater challenge often than actually the technology itself. And we need to remember that. So the sad situation in the Northern Territory at the moment is, despite the access people have now to these sorts of telehealth services, because of a lack of willingness, often on the part of the clinician in Adelaide, not necessarily the people in the Northern Territory, but a range of issues and cultural barriers, people aren't using the services. So they're using them, I think, perhaps 1% as much as they could be, like literally almost nothing, compared to what they could be using them for. And that meant that the people that lived in this remote Aboriginal community in Hermannsburg had to get on a bus in the morning. They put on a bus every morning to bus people to Alice Springs in order to access healthcare services. And the bus was always full. And if you didn't get a seat on the bus, well, you just didn't get your healthcare that day. You know, and that's the reality of what's actually going on in our remote and regional settings in Australia. And it speaks to that importance of thinking about the way we can better explore those behavioural changes and translate the innovation and research in health information technology. And another story I'll leave you with is I visited a really great, another Aboriginal medical service in the Cape, in Cape York in far north Queensland, north of Cairns, the Apunapima service, and they have 11 clinics spread around remotely. And I visited the one in Mossman Gorge, and one of the practice managers there had worked in a town called Hopevale, which was about 5 hours north of Cairns. And in order for all of the information, they kept a wonderful digital clinical information system that all connected to all the 11 clinics, and the population, the culture was transit, that they like to move from town to town, and they would be able to have access to their health information in whichever clinic they visited in the service. But in order for them to actually back the information up and get it into the cloud so that it could be viewed at all the different health services, this practice manager was driving an hour every day from Hopevale to Cooktown in order to get enough bandwidth to upload the medical record into the system. So this is the sort of, you know, we've got this, as I said before, this juxtaposition of the way, despite amazing innovation and technological advances, we're really faced with some really, they seem kind of fundamental basic problems, fax machines, etc. So, you know, the story of health technology over the last 10 years has not always been a good one, and it's the fastest growing business in the world. So I think that it's one of the most innovative as well. And from the perspective of, you know, what we want to have for our children for the future, and let alone ourselves, it's probably one of the most important areas to focus upon in information technology. There's obviously a lot of hype with health IT, artificial intelligence and genomics. It's really exciting stuff, and new technologies will change our world quickly, but they'll only flourish if we get the digital basics right. And we must be pragmatic and think about what else we need to do around the boundaries of information technology to make sure that those changes can be seen through and actually lead to those benefits for the society. So our vision for the future is, it's pretty straightforward really, to just let's get the basics right, and let's do that all together as a community, and make sure that we're taking government, industry, clinicians, citizens and researchers along that journey and working together as best we can. And coordinating that is part of the role of the Australian Digital Health Agency as well. So look, I think I'll leave it there. So, you know, thank you all for the great opportunity to speak to you today and talk to you about the way the agency is working with the research community and others to improve our digital health national infrastructure and deliver those benefits that we hope we're going to be able to achieve for all Australians. Thank you.
Thank you, Meredith. You happy to take questions?
I am, yeah.
So questions.
Lots of questions. Yes.
Thanks very much,
yes,
Meredith.
pleasure.
I'm an applied healthcare behaviour change researcher, so I'm very refreshed to hear you say that you've got to balance the technology.
Yes,
and behaviour change. I noticed on one of your slides about the uptake of the digital health record that the over 65s are the lowest, and they're arguably the population that need it most. So that's consistent with some work that we've done on digital inclusion. So I'm just wondering behaviourally what you think. Obviously, you're going to solve the access problem with the opt-out.
The opt-out, yeah.
What behaviours do you think we need to focus on in that cohort? Because they're the really targeted audience, aren't they?
Yes, it's a really interesting point, and somewhat of in some communities of over 65-year-olds, I've been confronted with quite, you know, an adverse reaction to that sort of attitude, because, you know, they pull out their mobile phone and say, I know how to use this, and I'm, very digitally enabled. So it's really not ubiquitous across that age group, but obviously there is a bigger problem. And as people age, and obviously we're also dealing with issues like the comprehension of how to opt out of a system, dementia, et cetera, et cetera. So we've got some special plans that we're developing for those, what we're calling hard to reach groups, of which the more elderly population and perhaps people with less developed digital skills, if you like, are one of them, which isn't just the elderly, but a range of other groups as well that we're thinking about. But look, also those statistics, just be mindful of the fact that there's been a massive push to enrol newborn babies. So there's a little bit of so you'll see a skewed figure there, I think, if you thought of it from a sort of academic standpoint of why the numbers looking like that. You'll see that there's actually a bigger population in that younger age group because we've been much more successful in simply giving those forms to the new mums as the babies are delivered in hospital, and everyone's sort of signing it up as they sign all those other forms while you're sitting in hospital with your newborn babies. So yeah, I think that's probably skewing it a little bit, but certainly we're very focused on making sure that we get this thing out. Yeah.
I'm a fellow of the Australian College of Health Informatics.
Oh, great.
And
yes.
Actually partnered with the agency recently at Macquarie University.
Yes. Yes.
To provide research in terms of health information technology.
Yes.
And one of the one thing I have observed is that, in fact you've alluded to it as well, is that multidisciplinary academic appointments are in fact almost crucial to successful research outcomes.
Yes.
So I just wanted to ask you your ideas about how we can promote the idea of multidisciplinary collaborations, adjunct appointments and honorees in research in health informatics.
No, definitely. And as you mentioned in your opening comment there, the agency has partnered, and in fact working very closely with Enrico Quira and others, and we're really focused on the way we can bring that to life. Our plans at the moment are we're actually developing a research placements program, which isn't isolated to clinical information technologists or other forms of IT specialists, or even IT. In fact, it will be an opportunity to have that multidisciplinary approach to bringing people in. I mean, they'll come from policy, from government as well, and thinking about the way people can perhaps do work experience and placements with the agency, but also with other organisations that we can coordinate with Archie and with Enrico and the system that's being established. But no, really, really very supportive of that, and looking at multiple strategies to try and encourage that. So we have I think I'd say it's sort of a multi-layered approach to the way we're actually investing new time and effort, and having a more structured, coordinated approach to the way we collaborate with the research community broadly. And one of the things that we're working on, and we hope should be finished, and look, as I said, we're a very young organisation, but one of the main pieces of work that I'm driving at the moment is actually creating a new research and evaluation framework for the agency, where we will actually be consulting with the academic sector very broadly over the next 6 months or so, and Enrico's part of a leading group that's looking at that piece of work. So I do hope that we'll have something out there that will be quite transparent and open to the whole research community, and give people a bit of a guideline as to how we hope to work and do that in a transparent and equitable way.
There is a question back. I just want to check that we're not ignoring Caulfield, though.
Oh,
Any
Caulfield?
questions at Caulfield?
Hello, Caulfield. I don't know if they can see me.
So there's a question at the back.
There's still people in the room, so they must be able to hear me.
I'm at the Monash Institute of Cognitive and Clinical Neurosciences.
Yes.
But my background is exercise science.
Ah, okay.
You alluded to genomics right at the very beginning.
Yes.
And that's a big challenging headache going forward, but something that can be very useful in this.
Yep.
The other major thing that has huge implications for health is lifestyle, activity and sleep patterns. And we have a plethora of...
I think huge are in the shorter term, in fact. Yes, but yeah, the lifestyle stuff, very important.
We have a plethora of accelerometry devices out there, but they're not integrated.
They sound painful, but anyway.
Government or national level records systems. But I imagine hugely interesting and useful information.
Absolutely. Yeah,
So
and that's
what's the
a common question. And we need to walk before we can run. I'll start there. But having said that, What's the time frame and what are we doing? So things like people often ask about their wearable devices, their Fitbits, all the great information that they're uploading to various apps and things. The vision of My Health Record is actually that it's a platform, a series of pipes, if you like, and all of the information about your health and care can flow through those pipes and connect, and you should be able to decide which of those various apps and things that you use and connect it to the record. So we've got, we're taking baby steps at the moment because obviously we have to take great care and exercise extreme caution with the privacy and security issues around letting an app connect to your My Health Record, and the clinical safety and quality aspects as well of deciding whether, essentially the health apps industry at the moment around the world, not just in Australia, is a buyer beware situation. We don't have any regulation, any process by which, me as your GP, I haven't got a book I can look at and say, well, I wouldn't look at a book, would I? I'd look at something digitally. But I've got nowhere I can refer to and say, well, that's got a Heart Foundation tick of approval, you can use that one. So we simply don't have a system. The UK are a little bit further ahead with us on this, but they're still struggling with it greatly. In fact, I was in London recently and spoke to the NICE Institute and talked about the way they're approaching clinical safety and efficacy of health apps. But we have a ways to go, and we need to do that with a multi-agency, whole-of-government approach and bringing clinical lead organisations together to think about that. So in the meantime, we've got a limited number of apps. There are 4 at the moment that have connected to the My Health Record system. Ones that actually are able to, it's a view-only situation at the moment. So we haven't gotten to the point where we're feeling safe enough to be able to authorise an app to take information and jig it around and feed you back something, which is what we want to do with some of those wearable kind of devices and apps that you're referring to. But it is absolutely the way I think that we'll go in the future. We see My Health Record as the platform and apps flourishing over the top of it.
So the next 2022 strategy.
Yeah, look, it's alluded to in the strategy without a dead, we're going to have 100,000 apps by 2022, but we have started the process, and I think we have to go back to making sure that we've got to build the foundations to make sure it's all safe. But yeah.
So that's 2 questions. Well, let's take these. Oh God, we've got to let one go get on a plane. So
no, that's all right.
But I'll take the 3 questions together, and then you can decide which of any of those you want to answer.
Sure.
Color.
All right. You talked about a problem with clinician uptake, and it sort of rung a bell in my head because I know of at least 2 other case studies, not in medicine, one mining industry, one actually here at the university 30 years ago, and that one was investigated, and the reasons were found to be quite unexpected.
Okay.
So I suppose my question is, have you looked at case studies in other areas of uptake problems,
okay,
and in fact tried to establish whether there are common factors between the problem that you're seeing in some area of clinical practice and some other area?
Yes. Okay. Did you want
Sarah?
Yeah, so I was interested in what you were just discussing. Is what I've seen so far of My Health Record is it tends to be summaries and it tends to be PDF documents, not the raw data.
Yes, that's right.
That
So
actually
a mixture, but yeah.
Well, there's not. I mean, the scans, say like radiology scans. You're not
there are no
keeping
images.
the scan. You're just keeping the report.
Yep.
If it's genomics data.
Yeah.
That's not, the raw data is not being stored there. So any processing that's going on is on a PDF of a summary of what had been seen by somebody else.
Yep. Yeah.
So are we headed towards storing the raw data, or is it really just going to be?
Yeah, no, absolutely. And so we've had to take a pragmatic approach, because if you can imagine that the system from which the information's coming would need to have the clinical terminology and coding behind it in order for us to actually be able to do the type of manipulation that we want to do.
Yeah.
So we have, for conformance systems that feed into My Health Record, we have established the ground rules, which is that they should be using that kind of coded data, etc. But we have made exceptions in the short term to that situation while we work with those technology companies to get up to speed and actually have that kind of backbone to be able to do that properly. So there's a big piece of work at the agency at the moment around interoperability, which is doing exactly that. It's a broad piece of work that's going to look at the way, but uptake of clinical terminologies around the world is also problematic. But we need to think about smarter ways to actually harness atomic data in the system so that we can do those sorts of things. The genomics story is also one that's a great big thinking longer term exercise. And I mean, we just haven't even envisaged the way, firstly, we're going to be able to store and handle that amount of information, or if it should in fact be stored in my health record, or whether it should sit in other secure repositories. And we do some very cool kind of blockchain way of accessing it and those sorts of things. But I mean, there's a whole world of future thinking, innovation and development, which is very exciting to be in. But obviously, it's something that I'm not going to make you a promise that by 2022 we'll have solved the genomics problem or even the atomic data problem. But we are very focused on trying to get the technical community, you know, the digital health.
Genomics is even more complicated because the technology for that is changing so fast anyway. If you made a decision today of what to store, it's not going to look like that by 2022.
Sure, yeah. And I feel like I ignored the uptake question over here, unmeaning. So I'll address that. Yeah.
I'm Matthew. I'm a graduate medical student.
Oh, great.
Working as a junior doctor next year. I'm just interested because obviously as junior doctors, you know, we are dealing with patients on a secretarial basis and working with this sort of records that will be on My Health Record. I was wondering what your opinion was on how the My Health Record will change the workflow as the junior doctor as uptake increases, particularly in terms of privacy and avoiding adverse drug events.
Well, I sincerely hope it's going to change it a great deal, and particularly at the first port of call as people hit your hospital system, which is going to be the emergency department. So we really need to work really hard with our jurisdiction partners around the states who are responsible for actually delivering the education and the use and adoption, that sort of piece of work. So we've got many hospitals around the country that are actually technically perfectly connected to My Health Record. In fact, discharge summaries are flowing up, you know, unknowingly for most of the clinicians in the hospital, but a clinician on the ground, on the ward, won't necessarily have ever heard of My Health Record, have any idea how to click a button and access it, have no idea, you know, just it's about simply informing them and getting that education built into the junior medical education that's going on as interns become familiarised with the other systems. But I do hope that actually we'll see people, Australians, actually driving, you know, demanding that we start to change and think about it, because they're going to be able to pull out their mobile phone and show you themselves. So that's the ultimate workaround, that we're going to actually be in a situation where we're changing that power balance, and people will be able to say, no, hang on a minute, I'm telling you I had that test, look, it's right here. You know, so it's a different situation to be in. We've seen examples of that already with, you know, just being able to access your immunisations, and systems go down in the hospital and mum pulls out the phone and says, yeah, she really did have that immunisation, here it is, you know. So it's a complicated, it's this behaviour change, education and adoption. We've got a big division of the agency that's devoted to that very exercise. Yeah.
I think we're going to have to end there, but thank you, Meredith, so much.
Pleasure, really great pleasure. Thank you for having me. Good. So.
Great.